it could be the difference between somebody walking and not walking.
In this episode, Dr. Lew Schon demonstrates how weight-bearing CT revealed that a complex Charcot deformity was confined to the midfoot, allowing preservation of the hindfoot and avoiding unnecessary fusion.
So the most complicated deformities are with destroyed joints. And nothing better to demonstrate that than a Charcot case. So this is a Charcot case. The gentleman is 70 years old, and you can see very clearly on x-ray something is not right here. The patient doesn't need three-dimensional imaging to see that the foot is all skewed on these images. But as a surgeon, we need to understand where we're going to be making our cuts, where we're going to be putting our fixation, and this is really well demonstrated with the weight-bearing scan. But here you can see the abduction of the foot, you can see the rocker bottom foot deformity, and you can see that the ankle joint's okay. There is some question of what's going on at the hindfoot. So I can't really see the hindfoot here. This hindfoot on the x-ray looks like it's arthritic. You just don't see a line because the foot's so collapsed. So we know we got a midfoot thing, but wow, this hindfoot looks terrible. Is this a hindfoot that needs to be fused? Now, the patient will see what they see and they're going to be fine, but you need to see that this hindfoot is okay or not okay. So the weight-bearing scan really makes a difference here. And so here we're looking at the hindfoot, and you can see, okay, this looks pretty bad. Okay, it looks, but oh no, it's not so bad. That whole subtalar joint is actually fine. So it looks bad because the shoulder of the talus is deep inside Gissein's angle. And there's a little cyst there, but we go back here and we can see that the whole hindfoot is actually open. And when we look at the talonavicular joint, that's totally normal. And you look at the calcaneocuboid joint, it's fine. So this patient's collapse is really through the midfoot, and it's a lot of destroyed midfoot, but no destroyed hindfoot. Hindfoot secondarily malaligned. And so, and you could, look at all the images and help plan this out very nicely, very easily. Okay, there's the impingement, and you see here the deformity is first, second, third MTC, and some calcaneocuboid, but really 1, 2, 3 is the problem, and we got that rocker bottom as you saw earlier. And therefore, on the base of that, we knew we need to do a reconstruction. And so here we are doing the reconstruction, planning out our wedges. And I planned it through the midfoot, not through the hindfoot. So here we are doing the wedges and then starting to put the pins across to stabilize it. Feeding the screws in. And then putting a plantar plate. Fusing the rest of the midfoot. And there we are. So this surgery, obviously complex, but we left the whole hindfoot intact. And you can see here, he doesn't have the rocker bottom anymore. You can see here the abduction is dramatically reduced, that he's now connected here. He still has some abduction, but I left all his hindfoot joints. So we don't have any of that extra stiffness, which means that his ankle and his hindfoot has not gone on to have arthritic Charcot collapse. And so that's, for this patient, meant that they are able to walk and function pretty much without impediment. Whereas before they were wearing a hole in the bottom of the foot. Now the arch is up, no longer down on the ground, no longer touching the ground. Right here you can see that the plane of the heel and the metatarsal is interrupted by the midfoot coming down. Now the midfoot is up and it's not a rocker bottom anymore. So this case again showed me that I have the hindfoot that's normal, leaving that hind foot, even though it looks funny on the x-ray, we're able to leave it for subtalar motion, which means he has better balance because he has bad proprioception because he's got neuropathy. And by not fusing the hind foot, we're not throwing the stresses to his ankle and again giving him more normal dorsiflexion, plantar flexion, more normal balance, more normal proprioception. It could be the difference between somebody walking and not walking. It could be the difference between somebody getting a next level Charcot versus just being okay with some goofy foot joints, but not really a foot that's has had the joints destroyed, which is what a fusion does. So this guy, because we didn't fuse his hind foot, his ankle's totally fine. His hind foot is the same as it was. He could still have balance. He could get up and down the stairs. He could walk. He gets around with regular shoes. He doesn't need an AFO brace. He doesn't need extra wheelchairs, extra walkers, extra hospitalizations. He doesn't need extra surgeries. I mean, he's a functional member of society. And had we overfused him, most likely we would see the effects of having that stiffness, worse balance, more falls, potential for Charcot at the ankle, and more disability, meaning people would have to help this person with their activities of daily living. I think most people would look at this over here and say, well, we've got this is bad, but the hind foot is also bad. And since you've got a Charcot, oh my gosh, everything's going to be bad. Might as well fuse everything. And people have gone through that approach saying, well, if it's bad here, it's going to be bad there. As soon as you do this, that's going to be bad. And the reality is that it was just that front edge of the sinus tarsi where the shoulder had impinged and created the cyst, but not the whole joint. Talonavicular was fine, calcaneal cuboid joint's fine, and you can't see that on the regular x-ray. If I didn't have the weight-bearing CT, I would get an MRI and look at that hind foot joint complex. It wouldn't necessarily tell me like the whole story because it's not weight-bearing. And the CAT scan would also be good, but not as good because it doesn't show you, again, the weight-bearing effects. Like you might see that subtalar joint's open, but is it really open if the patient was weight-bearing? So you don't have a real conclusive exam with a regular CAT scan. An MRI would probably be better from that point of view because you're at least seeing the quality of the cartilage there. Whereas the CAT scan, you see a space. Is that space filled with cartilage or is it fibrotic and arthritic?